Frailty is a very common condition in older adults. Since 2018, we have a new consensus definition from the European Joint Action Advantage, and it said that frailty is a condition age-related. It cannot happen in young people, and that is characterized by a decrease in the physiologic reserve of all our systems, and that leads to a vulnerability to stressors, and that leads to adverse health outcomes like mortality, disability, institutionalization, hospitalization, going to emergency departments. And it is an independent condition of other risk factors that are well known, like disability, comorbidity, age, sex, and other things, polypharmacy. So we have to take it into account when we treat every older person. If you want to recognize a frail older adult when you are you're visiting an older patient in primary care, or you're a specialist and a nutritionist, an endocrinologist, or an internal medicine specialist, you have some tests, some easy tests you can take to make like a screening for those patients. The most important ones are gait speed, that it's very simple to measure. If your gait speed is lower than a 0.8, you can be frail. You can also conduct an SPPB, the short physical performance battery, that is a more elaborated test. And then when it is under 9, you can be frail. And the other one is a time it up and go test, that it's also very simple to do. You have to walk to get up from a chair. You have to walk 3 meters and return. And if it takes you more than 20 seconds, you can be also frail. And if you want to diagnose frailty, you need to apply some criteria that are well defined. Probably the most used ones are those that were published by Linda Fried in 2001. This is a very interesting and long question to resolve, but I would give you some clues. The first one is the prevalence. The 3 conditions are relatively prevalent. We know that only 20% of older adults that are hospitalized are well nourished. So it means that 80% are or at risk or with undernutrition. So it's very prevalent in hospitals. In institutions, we know that 2/3 of older adults are at risk or with malnutrition. And in community dwelling older adults, we know that 40% more or less of older adults are also or at risk or with malnutrition. So it's very prevalent. Same happens with frailty. We know from pooled data from Advantage, from the joint action of the European Union, that the pooled prevalence of frailty in community dwelling older adults is about 12%. But when we move to prevalences of the population, of the whole population, including hospitals, institutions, the prevalence can reach 18%, so it's very high. And talking about sarcopenia, with the last criteria, more or less about 10% of older adults have sarcopenia. And when we move to older ages, like 80 years old, these prevalences are higher and can reach up to 1/3 of older adults. So these are prevalent conditions. And also the relevance is that they are all of them associated with health outcomes, like mortality, disability, hospitalization, institutionalization, all of them, and independently, although they are close related, but each one of these 3 conditions produces these adverse events. So I think we must take care of them in every old patient we take care of, and we have to screen participants and old people of frailty, sarcopenia, and undernutrition, the 3 conditions. This is another difficult question to answer because it has many points of view, but I will try to answer regarding if they share criteria. if they share prevalence, if they share physiopathology, and if they share treatment. Regarding criteria, if we take a look at the last ESPEN criteria of undernutrition, there are some phenotypic criteria and there are some etiologic criteria. Two of the phenotypic criteria, one is from Frailty, the same, and the other one is from Sarcopenia, the same. And if we take a look to the etiologic criteria, one is inflammation, that is the core of the physiopathology of both Sarcopenia and Frailty. So from a criteria point of view, yes, they are related. If we take a look to the relationship between them, we can see that more or less 10% of people who have undernutrition are frail or are sarcopenic. So there's a close relationship. And if you have frailty, 40% of frail older adults have sarcopenia. So not all of them are the same, but they are closely related. If we take a look at the physiopathologic pathways that lead to the functional continuum, including frailty, we know that there are 5 main pathways. The first one is a genetic susceptibility that takes account of 25% more or less of frailty, and it's also associated with undernutrition and sarcopenia. We have also some epigenetic changes that makes an accelerated aging and that can lead to both sarcopenia and frailty. We have undernutrition, very important, that is also in the physiopathological way of frailty and sarcopenia because it has to do with hormones, with taste, smell, palatability, anorexia of aging, increase of cytokines, many factors related. Also, sarcopenia is another pathway that leads to frailty. And the last one that probably is the most important is the low-grade chronic inflammation that appears in all these patients, and that is a common pathway, a common link between all of them. And probably it could be the main one. So if we had to try to go against frailty and sarcopenia, we should need to go against low-grade chronic inflammation or inflammaging, what is called. Each condition, undernutrition, frailty, and sarcopenia, have their own guidelines for treatment, but all of them have 2 common treatments that are nutrition and exercise. And there are also some other things you can do, like a good geriatric assessment in order to know not only if the patient is frail, sarcopenic, or malnourished, but also to know which are the factors that can be beyond these conditions. And also you need to assess polypharmacy, because there are some older adults that all the drugs are well prescribed, but others not. You can use some tools like the stop-start or the Beers criteria to adapt exactly the drugs you need to use in each population. And it has been demonstrated that using these rules, you can improve both nutrition, sarcopenia, and frailty. And of course, the most important are exercise and nutrition, that always must go together because they do a synergistic effect, improving all the conditions. I think exercise and nutrition are the 2 best demonstrated treatments in both conditions. A recent systematic review and meta-regression analysis that was published some months ago analyzed the 19 randomized clinical trials actually regarding treatment with protein supplementation and exercise in frail and sarcopenic older adults, and the results are impressive. They not only improve muscle mass, but they also improve muscle strength, both in legs and arms, and also they improve walking capability and disability. So it's been clearly demonstrated that the addition of protein supplementation and exercise makes the basis of the treatment to both frailty and sarcopenia. These treatments, as I told before, not only improve muscle mass, but also muscle strength, capabilities, and what is more important, function and quality of life. And in some randomized clinical trials, they have all demonstrated to improve cognition, affect, and also sociability and quality of life. So I think it's quite important. I think that with the knowledge we have actually, it's not ethical not to screen for frailty, sarcopenia, and undernutrition in older adults. This is my first conclusion. That we need to use simple tools to do so, and we have those simple tools, so do it. And I think the third conclusion could be that we know that these conditions have treatment, and the treatment is nutrition, mainly protein supplementation and vitamin D, added to physical exercise, and that physical exercise must include strengthening and power. So it's not only walk a little bit, it's not only you have to do more things, no. You must to prescribe exactly the physical exercise that improves muscle, and that is strength physical exercise and power physical exercise. There are some guidelines like R plus Activa or others that can be used for that purpose, and let's implement it.